Hello, my name is Emma Skye, and I'm Director of Yale World Fellows and co-host of the Good Society Forum. The Good Society Forum is a community of change makers around the world with a common quest to build the good society. My co-host is Nizama Dean of the Prince's Trust and a 2019 Yale World Fellow. Niz.
Thank you, Emma. Hello, everybody, and welcome to our Good Society Forum webinar. Thank you for joining us today and for being part of our community that is dedicated to building the good society. And in true building a community fashion, I would very much like to share with you what platforms we have that you can follow us on so you can keep up to date with our energy and the work that we're trying to achieve. We are on Twitter at Good Soc Forum. We are on LinkedIn. Please do follow us, Good Society Forum company page. And we are also on Facebook. And because we are a community, we are interested in actively building a good society that you care about. So if you have any questions or ideas or suggestions for sessions that we should be doing in the future, please do let us know. You can also email us, info@goodsocietyforum.com. So the plan for today is we're going to be hearing from 4 speakers on our theme, and then we're going to be taking your questions. Now, we are very keen for you to participate, and many of you who will have been a part of this already will know the drill right now, which is we want to know who we have with us in terms of our audience. So if you wouldn't mind, Michelle, there we go. I butchered your name last time round. I apologize, from Brussels. So if you wouldn't mind sharing where in the world you are tuning in from, please do feel free to type in your city in the chat function, which is below. We would really appreciate it. I think, here we go. Fantastic.
So we've got London, Las Vegas, Fitbill in London as well.
Harlem,
Oxford,
New Haven. We have good New York representation. I'm sure that's because of Diane today. So thank you so much for joining us. We have the Philippines. Arlene, you are very welcome. Thank you again for joining us. Sonali from New Delhi. Wow, I mean, it never ceases to amaze me just how global our community is all the time. Thank you for joining us. Please do share your experience with us today. We are, as you all know by now, we're covering a range of incredibly important topics. And of course, we are it's highly relevant to what's happening now with COVID-19, as is today's topic around why minorities seem to be most affected by COVID-19. So if you do think this is relevant to friends and colleagues, please do share our future forums, and please do share your experiences today on some of the platforms that we've talked about. So Emma, what's the plan for today?
So whilst everyone is at risk of catching COVID-19, the impact of the pandemic is not being felt equally, particularly in the most developed nations of the world. So data from the UK government shows that ethnic minorities have statistically significant raised risks of death involving COVID-19 than those of white ethnicity, with Black males 4.2 times more likely and Black females 4.3 more likely. In Norway, 6% of all COVID cases were among the 0.05% of the population that were born in Somalia. While in the United States, counties with higher African American populations account for more than half of all COVID-19 cases and almost 60% of deaths. Is this because ethnic minorities are more prone to underlying health conditions, or is there more to this?
So today, we bring together an exciting range of experts from the UK, the United States, and Norway to discuss the situations in their countries and help us to better understand these worrying trends and just what we can do about it. So our first guest is Dr. Amy Banerjee, who is an associate professor in clinical data science at University College London and an honorary consultant cardiologist at University College London Hospitals and Barts Health NHS Trusts. Dr. Amy is a practicing clinician with interests spanning health, informatics, learning health systems, cardiovascular epidemiology, global health training, and evidence-based healthcare. So we're going to ask Dr. Amy to join us and over to you, Dr. Amy. Looking forward to hearing from you.
Thank you very much, Nizam, and thank you very much for the invitation to join you. So I'm part of the time a clinician. I'm actually a cardiologist by trade, but I, like many of my colleagues around the UK and around the world, found myself practicing in very different circumstances to what I was used to. For most of the last 6 weeks until 3 weeks ago, I was actually working in the intensive care unit at the Nightingale Hospital, where, you know, I'm not an intensive care consultant, but was working there. And one of the things that we noticed just from our experience was the ethnic disparity of patients that we were seeing just when we looked at our intake. And this was reported to me by colleagues from around the country. Early on, I have a separate role as trustee of the South Asian Health Foundation, which is interested in studying and eliminating inequalities that are due to ethnicity and socioeconomic related inequalities. And this was coming from Birmingham, from Leicester, from Manchester, similar observations. And in our own research, I've been looking at what's called the excess deaths, which are terms that have entered the vernacular now. So the deaths that are due to this global COVID emergency, which are beyond what we expected and what we've seen in previous years. And we have seen that those deaths predominantly occur in people with underlying conditions and people who are older. And that's seen in lots of different data sets. And one thing that's clear, whether you're a researcher or a clinician or a citizen, is that the only thing today on May 13th still that we have in our armory to tackle this epidemic and pandemic is to keep the infection rate as low as you possibly can. And we're obviously in this stage in the UK where we're easing lockdown or about to ease lockdown. So there is tension, and we want to know as much as we possibly can about many aspects, including the angle of ethnicity. So in my context in the UK, it's clear that across several data sets now, including data from the Office of National Statistics, which is reporting cause-specific deaths, so we know the deaths that are due to coronavirus and the deaths that are due to other causes, that shows a 2 to 3-fold increased risk of death in people who are Black, Asian or ethnic minority. And that has been shown in primary care data sets. A large data set of 17 million individuals was shown last week, led by Ben Goldacre from Oxford, to also show about a 2-fold increased risk associated with these minority ethnic groups and COVID-related death. And various hospital-based and intensive care data show the same. So this is a robust finding. It's not a chance finding, as the announcers said at the beginning, as Emma said. This is statistically significant. So what's the cause? I think a lot of people have spent time, is this due to underlying causes? Now, in our own analyses, I can't see evidence that this can be explained by underlying, for example, risk of diabetes and cardiovascular disease in these populations. And it's much more likely to be due to what we call proximal determinants or social determinants of health. So the causes of the causes, poverty. If you look at, for example, the Black population in the UK, 40% falls into the most deprived quintile of the population, whereas in the white population, that's more like 10 to 12%. And the other ethnic minorities are in between. And So undoubtedly that may be playing a role. Are there cultural differences in terms of the way that overcrowding may be happening, related to the socioeconomic, but also related to cultural aspects in certain communities? Is it also that, you know, there's been a lot of speculation about health professionals, where again the deaths, whether in social care or healthcare, have predominantly been in people from ethnic minorities, and there it's very, very clear that we don't want to delve into the world of you know, people are worried about doing or saying things that are politically incorrect, but actually we need to find out the causes. Are my colleagues more likely to be put in harm's way? Are they less likely to have the personal protective equipment that was required and is required and will be required during this pandemic? And that we need to find out. And that's why the government has taken this very seriously, and to be fair, has set up this inquiry to look into this urgently. And has also, there's various hospitals where workers like myself are being asked if we're okay with working on the front line. So this is an urgent need, and we are seeing, I know data from America and other settings that's showing something similar. So I'll stop there in the interest of time.
Thank you, Amy. Our second guest is Dr. Abdi.
Sorry, Emma, we lost you there for a second.
Can you hear me now?
We can.
Our second guest is Dr. Abdi Geller, a researcher at the Unit for Migrants' Health, which is a part of the Norwegian Institute of Public Health. His main research interests span the fields of maternal and reproductive health, epidemiology of tuberculosis and HIV, as well as health promotion, intervention, and policy evaluation of measures targeting health of immigrant populations. Dr. Abdi.
Thank you very much for inviting me to this program. Immigrants are disproportionately affected by COVID-19 in many countries in Europe and United States. They are not only overrepresented by people who are infected by the coronavirus, but also people who have been hospitalized because of the severe form of the coronavirus, as well as people who unfortunately died because of the infection. Norway is not different in that aspect, but the situation is not dire or terrible to the extent that immigrants in other countries are affected. For example, people in Norway, immigrants in Norway constitute 15% of the Norwegian population. But they constitute also 20% of people who have been infected by coronavirus, as well as 33% of people that have been hospitalized. One thing that is quite interesting here is the average age of the people who have been hospitalized because of coronavirus in Norway is 64 years. But immigrants from Somalia and Iraq, the average age of the people that have been hospitalized is 50 years, much younger. And we are trying to investigate the reason why immigrants develop severe form of coronavirus at that relatively young age. In Norway, immigrants in that underrepresent people who died for coronavirus, and that the young age of the hospitalized individuals might explain that the low rate of immigrants who died for coronavirus. The reason why immigrants is overrepresented or vulnerable to the infection are brunt, not 1, 2, or 3. But those reasons mainly revolve around socioeconomic factors, access to health services, and access to tailored and brunt health information about the pandemic to immigrant communities. Most of the time, most of the countries, we talk about immigrants, but we should know that immigrants are people who came from all the corners of the world. In Norway, for instance, majority of immigrants in the country came from European countries like Sweden, Denmark, and East European countries like Poland. We have another group of migrants who came from Asia, like Pakistan, India, Sri Lanka, and also others who came from Philippines, Thailand, Burma, and Vietnam. We have refugees from Middle East, like Syria and Iraq, and another group who came from Sub-Saharan Africa, like Somalia, South Sudan, and Gambia. These different immigrant groups have different vulnerabilities as well as different coping mechanisms. For example, Somali immigrants constitute only 3% of the immigrants in Norway, but they represent 25% of immigrants who have been infected by coronavirus. In my institute, we stratify data from the immigrant populations by country of origin, so that groups that are hardly hit by the pandemic shouldn't disappear within that category, broad category of immigrants. And I will recommend all countries, the practitioners, researchers, policymakers, civil society organizations should advocate data to be stratified into that, so that a certain group who is more vulnerable shouldn't disappear, and therefore, and thus remain unaccounted for when designing interventions. Thank you very much. That's all I'm going to say here.
Thank you, Abdi. And our next guest is Professor Lucinda Platt, a professor of social policy and sociology in the Department of Social Policy at the London School of Economics. Lucinda's research and teaching focuses on inequalities, in particular relating to ethnicity and migration, gender and disability. Earlier in May, Lucinda co-authored a report with the Institute for Fiscal Studies and Nuffield Foundation entitled, "Are some ethnic groups more vulnerable to COVID-19 than others?" Lucinda.
Thank you very much, Emma. And I'm just going to share my screen so that you can see some of the illustrations. Interesting. Sorry, I can't find where to share my, oh, sorry, it's in a different place here. So while I'm doing that, I will say that I work on ethnic inequalities, and I became interested in this, doing some research on this topic when I was seeing some of the initial figures that had come out. And I was concerned also that when in the discussions there was a tendency to group all minorities together as if there was something necessarily about being a minority that made you more at risk. What I and Ross, my co-author, wanted to look at was we wanted to look in more detail at factors that might be helping to explain this, but also might be more revealing of inequalities across groups. We disaggregated by ethnic group, and we also looked at geography, because it was clear that that in more urban areas there were more deaths, and that these were areas where you were more likely to find minorities as well. So, for example, over 50% of Black Caribbeans, Black Africans and Bangladeshis live in London. High proportions live in Birmingham as well, and some of the other areas. So a figure like this, which shows rates per 100,000 of the population, is not necessarily very informative, because it doesn't take account of geography, but it also, more crucially, it doesn't take account of the differences in age across the populations. And most minority groups are younger. So those groups that look like they don't have disproportionate death rates on a per capita basis do as soon as you start looking at adjusting for age. And so adjusting for age and geography, we found these very distinctive differences in risks of mortality relative to the white British. We adjusted we used hospital deaths, but we used information on where deaths were occurring at local area. And then people were saying, but what about care home deaths? Obviously, there have been a lot of deaths in care homes. So we adjusted our estimates for the fact that over 95% of people in care homes are white, and therefore we assume that the majority of those dying in care homes were also white. And even then we found that Black Africans in particular were disproportionately likely to die. They were more likely, they had higher rates of excess mortality, higher risk of mortality up to 3 times compared to the white British population. Pakistanis were 2 times, and Black Caribbeans 1.5 times. So, but all the minority groups suffer this excess risk, and I think it's really worth looking at the differences in groups. So then we looked at the question of why, and one of the things that's been raised, I won't try not to repeat what's already been said, but one of the issues that has been raised is exposure. What jobs are people working in? What was very clear was that in terms of working in key worker occupations, and particularly in health and social care, there were very large differences across ethnic groups. And again, it was Black Africans who were particularly likely to be working in health and social care roles. And if you go down to individual types of occupation, if you look particularly at social care roles, where ONS has shown that there have been disproportionate rates of death, then these rates are very different. So, and they're different by sex as well. So we know that men are more at risk of dying. Black African men are 7 times as likely to work in social care roles as white British men. So we think there's something about occupational exposure. We also think there's something about going on in terms of underlying health risks. So we looked at some data on that, and that suggested that different groups, in particular Pakistanis and Bangladeshis, were facing greater rates of underlying health risk, which themselves are in part associated with poverty and socioeconomic deprivation. But of course, there are other factors that continue to be relevant as well that we haven't looked at yet. But the story was clear that some of this might be explained by occupations, some of it we still need to understand more. And we also thought that there's the mortality risk, but there's also the economic impacts of the shutdown that's occurring in the UK, but also many other places. And this economic cost of the virus is also disproportionate. And that may itself have long-term health consequences. So we looked at the rates of people working in shutdown industries, and we found these were much, much higher for Bangladeshis, and much, much higher for Bangladeshis in midlife compared to the youth, who were tended to be more affected overall across the population. And these were therefore people with families and therefore with dependents. And so the implications go much further than just at the individual level. I'm aware you only want me to talk for 5 minutes, so I won't say any more about that, but just to draw attention to what both these sides of the picture draw attention to is the concentration of immigrant and minority workers, very highly concentrated in particular occupations, and we're seeing that those are the occupations now which they're needed, but they're not highly valued in terms of economic rewards, jobs in social care, for example, or jobs in hospitality and catering and taxi driving and transport. And we're seeing now that there are some very devastating consequences of those patterns of occupational concentration, which I really think we need to think more deeply about. So I'll stop there.
Fantastic. Lucinda, thank you so much for your presentation, and in particular for highlighting the longer term consequences also of COVID-19 and the impact that is likely to have. So up next, we have our final guest before we open it up to Q&A and questions to our speakers. So please do, if you have questions, we are receiving them. I am collating them, and I will be putting them to our speakers. Our final guest is Diane Morales, who is currently running, very excitingly, for the Mayor of New York City for 2021, and was until earlier this year the Executive Director and CEO of Phipps Neighborhoods, a leading organization that works towards a New York City in which no one is caught up in a cycle of poverty. Diane is an expert in education, workforce, and youth development issues, having previously served as the Executive Director of The Door, one of New York City's premier youth development organizations. Diane, thank you for joining us. Over to you.
Thank you. Thank you. And thank you for that introduction. Just to add a little bit further, I am also a Black Puerto Rican first generation college graduate, born and raised in the Bed-Stuy community of Brooklyn, New York. I've taught in New York City public schools. I've worked as a caseworker in the foster care system here in New York City. And as Nazim mentioned, I recently stepped down from my position to run for mayor. I would say that while the pandemic has universally changed normality for everybody, it is not the great equalizer that some have claimed. In New York City, those with second homes packed their cars and fled the city, leaving empty buildings and quiet streets behind. By contrast, those who have remained largely fall into two categories. The first would be those who could and began to shelter in place relatively safely and avoiding the infection while working from home. And the second are those for whom sheltering in place meant that they had to continue exposing themselves on a daily basis because their jobs were such that they were suddenly deemed essential. These individuals don't have the luxury of continuing to earn an income in the safety of their own homes. Their jobs are essential for the survival of the city, yet these workers are still earning minimum wage, which is a direct message from society that clearly tells them that they are disposable. These workers include our grocery clerks, our bus drivers, our maintenance workers, the delivery people, and healthcare workers. Not coincidentally, they are also disproportionately Black people, heavily comprised of immigrants and women, and they make it possible for wealthy white people to stay safely in their homes. In New York City, frontline workers represent approximately 25% of the overall workforce, yet 79% of our frontline workers are Black and Latino, and approximately 63% of them are women. Overall, they represent about 62% of the fatalities in the city. They're generally underemployed, make the lowest wages, and lack access to adequate health care. While the data from the current crisis points to irrefutable disparities in infection and death rates in these communities, to me, the most compelling case that those numbers make points to the deep-seated, underlying, and long-standing structural patterns of inequities and disparities. It also highlights some of the tensions that have existed throughout the history of this country between individual rights and the good of the community at large, which can be seen most directly in the current protests against closures that have been implemented as public health protections. Those arguments for personal liberties are often invoked by white people at the expense of Black communities. The rush to reopen without appropriate measures in place would sacrifice Black people at the altar of the United States economy. But individual rights and self-interest are not enough, and a failure to recognize our interdependence now runs the risk of incurring a second wave of outbreaks that will prolong our ability to recover overall. The pandemic of racism existed in this country long before the pandemic of COVID-19. The pre-existing social conditions, if you will, that are reflected in the lack of access to affordable housing, employment that allows for economic stability, quality education and healthcare, These things are part of the aspects of the social contract that Charles Mills has referred to as the racial contract, whereby the same rules and freedoms that apply to whites don't apply equally to non-whites. And there's an underlying assumption of white innocence and Black guilt. That also can be seen in the differences in how communities are currently being policed, where Black people are being brutalized for failing to exercise social distancing, while their white peers in crowded public spaces are being provided with masks instead. The curtain's been pulled back on the myth that the rules have applied equally. We've not actually all been in this together. I heard someone say recently that we're in the same storm, but we're not all in the same boat. Moreover, this crisis in particular has highlighted the extent to which the individual pursuit of happiness is inextricably linked to the collective. But there's a transformative potential in this crisis, I believe. This is a moment where we can create a new social contract that rewrites the narrative on how we begin to address the deeply ingrained racial inequities and inequalities, and move towards a New York City where everybody can truly have access to the opportunities that they need to fulfill their potential. I think it's up to us to determine whether we choose to see that and what we decide to do about it. Thank you.
Diane, thank you so much for that very powerful presentation. I'm going to invite everyone back on so we can have our Q&A session, and we would love for more questions to come through. We have loads already, so I will certainly make sure that is being put to our panelists. And almost as if this was planned, unfortunately, Dr. Abdi seems to have lost his internet connection. But we did have and I promise you this wasn't planned, it's fortuitous. We have Claire Carlson, Business Development Manager and Diversity Strategist at Mittliv, a Swedish social enterprise and the country's largest mentoring program for people with a foreign background and post-secondary education, who's joined us for this Q&A segment. And I will come to you, Claire. And so we've heard some incredible perspectives around the issues, and very much our ambition with the Good Society Forum is to bring interconnected issues and lay scrutiny on them in a manner that allows us all to go away and actively build a good society. The first question I have is, Amy, we heard from you about the UK taking this seriously, and we know there's a public inquiry happening. I would love to hear from an American context and also from a Swedish context to whether this issue that you've clearly articulated by way of numbers to be serious, is it being taken seriously in your countries? Maybe I can start with Claire first. You're on mute.
Yeah, hey. Interesting, tough question, I must say. I would say yes, and at the same time, nah. Can I hand over to one of the other panelists whilst I just try and formulate a little bit?
Of course, no worries. Maybe
yeah.
Diane, I can come to you. I can come to you, if that's okay.
Yes, sure. Can you restate the question? I want to make sure I heard it correctly.
Absolutely. So Amy mentioned how in the UK, authorities seem to have caught on and are taking this seriously. And there has been talk of a public inquiry into this issue. Do you feel maybe whether the governor of New York, or whether the federal government is taking this seriously in America?
So I would say this to that. I think that there was an interesting shift in the sort of public health policy and protocols, the narrative that is being utilized by our government, our federal government in particular, that took place once the data about the disproportionality started to become clear. I think there was a direct correlation between that data becoming available and the narrative changing to the need to push to reopen, which to me communicated a very clear message about the impact that it made to get the information as to who was being most impacted by the virus and the disposable nature of that population. I think that, it's interesting because two people can look at data and interpret it completely differently. And so where for communities of color, it sort of, I think, started to sound an alarm. It feels to me like on a national scale, that information caused a reversal of the public health protections that were being put in place and a push towards reopening the country, which I think is problematic.
Thank you, Diane. And Amy, I have a question here from Nicholas, who has specifically asked the question, has there been any study to rule out the association with specific comorbidities? And it'd be great if you could explain what that term means for those who are sort of non-medical degrees.
Sure. So comorbidities or morbidities are underlying conditions or diseases such as heart disease or diabetes or chronic lung disease. And comorbidities, as the name suggests that you have several of them. Now, we know in various countries that people from ethnic minorities have predisposition to certain diseases and risk of those diseases, such as in South Asians, diabetes and cardiovascular disease. And similarly in Black populations, as Lucinda eloquently said, there's differences between different ethnicities. Now, we have some preliminary analyses that we're doing to look at a high-risk group for death from COVID infection and looking at whether those conditions are in themselves sufficient to explain the difference. And so far, as I said, we don't think that, that there is a major difference at population level in those risks. And secondly, that even if there is, it's not sufficient to explain this discrepancy. There's no published data on this as yet, to my knowledge. Can I, on the previous point, I just wanted to say that any inquiry that's done in our country is dependent on trust of the public and trust in the inquiry process. And unfortunately, we do have, on grounds of ethnicity and socioeconomic inequality, we had a Grenfell inquiry recently where the action has been appallingly slow or non-existent. So, we're all urging our government to be serious about this.
And I mean, you make a really important point there. I mean, we've had two inquiries recently in terms of Windrush and Grenfell, both of which have sadly lost the trust of the public. And so I think you're quite right. There's a question here from Taffy. We've thrown a lot of data out there, and we've seen in each of our countries, our governments putting a lot of data that they're publishing day to day. How accurate is the data that we're seeing? And I ask that in a very loose way for you all in your own respective areas to answer. So if I may come to Lucinda first as the person who's written a report and on this agenda.
Yeah, so the data aren't straightforward. So we have had, initially we just had hospital deaths, and hospital deaths are not recorded. So we have hospital deaths broken down by ethnicity because the ethnicity of people in hospital is recorded, but ethnicity is not recorded on death certificates. So we don't have necessarily the ethnicity of everybody who dies from the death certificates. So there's complications in the data. ONS, the Office for National Statistics, provide very good data on deaths, but they can't break that down by ethnic group because they're using the death certificates. So there is a process of matching up. Having said that, having made it sound rather complicated, I'm absolutely confident that the analysis we did does show genuine disproportionality. That's not to say there might not be things we can find that might help to explain that, but it's robust. I mean, Emma referred to the ONS data. It gave slightly different numbers, but the picture was the same. And we're looking at really striking patterns here. And age explains so much that the age profile really matters, taking account of that. So it's not a factor of bad data, even if we have to use it slightly carefully.
Thank you, Lucinda. If I can go to Claire, maybe to answer any of the questions that we've raised, or to maybe paint a picture of what's happening on the ground in Sweden on this agenda.
Yeah, no, absolutely. And so in contrast to the other panelists, I'm not a researcher who has access to lots of the data, as you guys all have. I would say that from what we can pick up from the information which is coming out to us anyway, is that it's very difficult to judge what's happening in Sweden because there's so little testing going on, and so it's difficult to see what's happening from that point of view. When it comes back to the first question that was asked, with regards to, you know, how seriously it's been taken, I would actually go back to say I can't see any evidence of that it's being taken particularly seriously. There's when I've tried to find information with how the government or authorities are looking at it, they are they're releasing information to show that yes, there's disproportions, especially it's similar what we've already heard for groups from Somalia, groups from Iraq, which are highly disproportionated. But at the same point in time, we have no lockdown. The recommendations are that we work from home, and as you know, we've already heard from Diane talk about the fact that, you know, that basically is a particular group in the community that has those opportunities to work from home, and there's a huge overrepresentation in the same way as Diane stated in New York City with immigrants in positions that are now classed as key and can't work from home, and that goes to, in my mind, show that no, it's not being taken particularly seriously.
Thank you. And Diane, if I can come to you, and I think and what's interesting about hearing the different perspectives is a clear thread being shown as to the correlation between health determinants and socioeconomic determinants here. On the data question, because I think data is the one thing which allows comparison. How I guess how good is the data that you have access to, and do you feel it's being measured? So I'll give you an example. Deaths in the UK don't mandate ethnicity to be measured as part of it, for example, and there's been a push by the Mayor of London to make sure ethnicity and religion in particular are measured, so that we could have got caught of this earlier in the crisis rather than finding out anecdotally first and then later through lots of people, lots of good work being done later on. Is there a similar issue in New York City, or is it different?
I would say that the question is not about whether the data that we have access to and that is available is reliable. I would say the question is whether or not it is complete. The disparities are irrefutable. The differences are so stark that, as one of my fellow panelists mentioned earlier, you know, even if accounting for slight factors or slight variables that might impact the overall data set, the differences are there. They're undeniable. There's an organization, AMFAR, in partnership with the Emory School of Public Health down in Georgia, did a national study of Black counties, and disproportionately they account for over half of the coronavirus cases in the US that are those are the known cases, and nearly 60% of the deaths. And so, you know, again, of the data that we have access to and that is available, it is irrefutable. I think there are people that have died at home, particularly in New York City, that the data is harder to track. There are now, I think, people beginning to die of what would be considered sort of secondary impacts. And by that, I mean the folks who might be feeling ill and choose not to go to the hospital because of the fear of getting sick, in fact, or folks who are homebound and unable to access food resources. Those numbers, I think, are going to be astronomical. But I do believe that the data that we do have access to, insofar as looking at that data, is accurate.
And Diane, I have a question here from Lord Simon Woolley has joined the webinar, who is chair of the UK's race disparity audit, and arguably one of the leading voices for race relations in the UK for the last, I would say, 30 years at least. here in the UK, there are some powerful people in positions of power who will use spurious genetic science to blame Black people for dying in greater numbers. Is something similar happening in the US?
I mean, yes. The short answer to that is yes. You know, whether it is our you know, the head of our Surgeon General telling communities, Black communities, that they needed to take better care, implying that that there is something that they need, that we as individuals need to do differently, as opposed to the social and collective responsibility. For me, that would be what is described as the culture of poverty, where there are these sort of malignant characteristics applied to Black people in a manner differently than they are applied to their white counterparts and peers, invoking the supposedly bad behavior of these groups as the reason for their hardship.
Thank you so much. And we have, and I think I'll go to Lucinda here in particular. So we have a question from Samir, who is asking the broader question in terms of, is it minorities or is it economically disadvantaged groups here? And I guess follows up with also a lack or difficulty of access to healthcare, which I think your research does find. Is that correct?
So it is quite difficult disentangling the socioeconomic and the minority status. I mean, I'm following up on the previous point. I mean, I don't think there's any case to be made that somehow ethnicity or your ethnic group is going to explain something in itself. It's what that ethnicity implies, what circumstances it implies, what job you're in. And as was mentioned before, even if you've got underlying health conditions, those underlying health conditions need to be related to what experiences have led to that. And we know that poorer people have the worst underlying health conditions. It's a very strong social gradient in health. So socioeconomic is part of the story. I mean, interestingly, there was some analysis by the Office for National Statistics, which trying to link people was trying to link people on their socioeconomic background, and that suggested that geography, where people lived, was much more of explained a lot more of the difference than people's individual socioeconomic background. But that may be partly because these things are associated. Poor people tend to live in poorer areas, and we've seen a very strong element of the poorer areas have higher rates of death. So I think socioeconomic is an important factor, but it's quite a complicated one to disentangle.
Thank you, Lucinda. And Amy, there's a question here which I'd love to put to you from Taffy. Is it because there are more employees who are ethnic minority working in the health sector on low-paid jobs with increased risk of infection, and also cross-infections to their family and friends? And I want to add a bit more to that. So I think we've heard from Lucinda, it's difficult to disentangle, but there's obviously an overlap between ethnic minorities being disproportionately in areas of high deprivation. But we know that 94% of doctors that have died in the UK have been an ethnic minority. We know 70% of nurses that have been killed, sadly, because of COVID have been from an ethnic minority. Doctors generally don't live in high areas of deprivation. And how do you reconcile that?
You made a Freudian slip and said have been killed.
Have died. Yeah.
But yeah. You know, there are, you know, if you don't have the equipment to work safely, then who's responsible? And there was data from the Office of National Statistics this last week about occupation, and first of all it showed that those in the lowest paid jobs are most at risk. Those who are not in permanent jobs are most at risk, and actually the people in health and social care most at risk were social care workers, who are very much overrepresented by Black and ethnic minority communities. Even more so than in health, actually. With doctors, I think we have to really drill down into the different professions. You're right, it's less likely that doctors, the socioeconomic issue is there, but as I said, have they been in particularly procedure prone specialties, places where they were more exposed to the virus with lack of equipment? Were they less enabled and empowered to speak up and not go into those situations? And those are the kind of questions that we have to, fearlessly ask, because I myself have lost colleagues. I would be lying if I said when I worked on the ward it wasn't crossing my mind, and that's that's something that we must find the answer to. But I also there's a quote that rings my ears from Michael Ryan, who was a WHO senior representative right after Wuhan, who said that we shouldn't let perfection be the enemy of action here. So we can sit here scratching our beards and doing PhDs and research for many months and years to come, but we need to do something about this now. And I think genomics and all of this is in relation to this is not the right cul-de-sac to go down. People are talking about vitamin D deficiency being a cause in South Asians as a legitimate hypothesis. Absolute waste of time, waste of money. If you want to tackle this, then you have to ask difficult questions, not play with data.
Lucinda, I have a question from Arzu specifically for you, and then we have some questions for Diane and for Claire, which is, whilst it's great that our government is investigating, so the British government, the causes of disproportionate impact of COVID-19 on BAME communities, how can we ensure that the inquiry focuses on the structural inequalities which both of your research and your work highlights, and that there is not, as you've just said, Amy, an overemphasis on genetic biological factors? What more can be done on that front, do you think? Amy first.
So I would say that, paradoxically, the clinical research that needs to be done most in this period of an emergency, there's a lot that can be done that's qualitative, that's social science, that's health economic, but there's a lot that needs to be done at the front line, at the coalface. So you need clinical academics, but for example, I had 8 days off myself with COVID, and so we need to be really picky about the research questions we pick and what we do, because otherwise they might not get finished or they might not get started, and so that's why I'm absolutely clear. We don't want to be going down this rabbit hole of genomics in this particular question, because we've done that to death. We need to absolutely tackle the when you say structural, I think there's patient level issues of access to care. If I get COVID, am I less likely to present to healthcare? Is it an exposure issue about my job, about my overcrowding in my place of habitation or my place of work? Now we're in a situation where we're easing the lockdown in the UK. When you see the pictures from this morning of buses and trains again being crowded, you worry that again, who's on those buses and trains? It's the people who have to go to work and can't work from home and are going to an overcrowded setting. And we know who's overrepresented there. So I think, we can get those kinds of data relatively easily.
And Lucinda, if I could ask you to maybe comment on that, and then ask you more broadly, could more work be, do you feel enough is being done in terms of the interconnected manner in which this issue has clearly been articulated and is being shown? Is enough work being done in terms of social policy and health policy working together day to day in addressing this and using this? And I know this sounds a bit, I don't want to use the word opportunistic, but there is an opportunity here where we are clearly seeing inequality fault lines being exposed. So is there an opportunity here to work together in a more permanent way to address these issues so that they don't occur in the future?
So I think it would be optimistic to think that things wouldn't occur at all in the future, and there has to, as mentioned before, there has to be a political will. to actually engage with this seriously. But I think you're quite right. I think we need to keep pressing. As I said, not that there's something about ethnic minorities that we need to look at, but there's something about the jobs we're asking people to do, the way they're getting treated in the particular jobs, why we have such a problem as issues in social care, where we have very badly paid social care workers who then are working under conditions that are not conducive to their health. I think we have to ask serious questions about aspects of immigration policy as well, because a lot of the minority workers are foreign born, so they may be going to work because their visa status depends on them going to work. They also may not have rights. Many of them may not have rights to social security, to the safety net, if they don't go to work. So they're in a very vulnerable situation in terms of employment. I think it's, as you say, an opportunity to start really honing in on some of these bigger structural issues that are being shown up by these deaths, and think about, yes, why are people in these jobs? Why do we have such a concentration of people in not just in care workers, but more marginal jobs who are being devastated by this. If we look at some of the other jobs where people have, security workers have been very badly affected, they've got, in terms of disproportionate deaths. So it's not a group we obviously think of, but if you look at the ethnic composition of security workers, they're overwhelmingly ethnic minorities. So again, this is a job that's not well paid, it's bad conditions, and people may be feeling bound to keep turning up. So I think we need to have a whole conversation about those sorts of jobs.
Thank you so much. And Diane and Claire, so we've had a range of comments from Michelle in Brussels talking about minorities are poorer and essentially the economy and their place in the economy. We've had comments from Taffy about what solutions do you put forward and in terms of socioeconomic disparities. And so, I'll articulate what Alban has said here, which is we have a medical emergency and there will be an economic consequence to follow. How can governments stop the same disproportionality hitting those communities through the economic shocks? So Diane, if I can come to you for that question.
Yeah, sure, in 30 seconds or less. So, you know, I think that what we're talking about here is, at least from my perspective, is pre-existing social conditions rather than pre-existing biological conditions. I think that speaks to why poor and racialized people are less likely to get tested early on, more likely to be turned away from the hospital if they have symptoms, less likely to have insurance, more likely to be working in these essential low-paying jobs, and less likely to have the options of sheltering in place. Until we address those structural social issues, I fear that we will continue to repeat the same pattern. And so I think that moving forward, you know, the upside, if you will, of this current situation is that I think it gives us an opportunity, with all of these disparities really, really glaringly obvious, it gives us an opportunity to rebuild a new social contract that centers, as I believe Lucinda was referencing, that centers those workers and provides them with basic needs and addresses their basic human needs in such a way that they are better able and better positioned to execute on the functions and roles that they carry in our society. But we need to be able to value those. That we are inextricably linked and interconnected, and until we move forward through that lens, we will continue to perpetuate these disparities.
Diane, thank you. Claire, do you have any thoughts as to what more can be done?
Yeah, so here in Sweden, we've been working for the last 12 years with both the private and the public sectors, trying to raise awareness and move them into action to actually start engaging in activities which will not just increase awareness about diversity and inclusion in the labour market, but actually, you know, go into action with that and start seeing differences in the recruitment and in the succession of an equality within the labour market. And that's what we're still doing. So today, this morning, we held a similar seminar, but instead of having the medical focus that we've had this evening, we had the focus on like the impact on the labour market, the impact on these individuals, why it's affecting affecting them more, how the economical status of that is affecting more in these groups, and what we need to do, and that we cannot lose focus on these diversity and inclusion issues now. When the going gets tough, companies sometimes, you know, stop looking at these softer issues. I say softer issues from a traditional point because they're not at all. They're incredibly important. And so now is going to be a real telling time for those companies. Are they prepared to stand up and keep fighting for this in the future? And we're there to provide them with that support all the way. So.
Claire, thank you. So we're nearly out of time, and we've been so lucky to have such a breadth of expertise and experiences and views that you brought to the table. It just shows how complex the issues are, but all of which are leading to, sadly, an outcome that we're all seeing in our city. So there's one question which I would like to ask from Andrea, who's in Las Vegas, which is, knowing what you know now, if you could see one change in policy on this agenda, what would that be? You have 10 seconds each. I'm going to go to Amy first.
Earlier lockdown.
Thank you. Lucinda.
So Amy pinched mine, so I would say better PPE, including in care homes.
Thank you. Claire?
Sort out the social disruption that we have in society. I can't say more than that.
Profound. And Diane, last word to you.
I would say radically different priorities and investments.
We're so grateful to each of you for joining us. Thank you so much. And this conversation will continue for us. This is an area of work that we all think is crucially important. So it doesn't end here. This webinar will be on YouTube within a few days. And for those of you who we haven't been able to answer your questions, we are sorry, but the conversation will continue, we promise. Emma.
So thank you very much to our panelists and to our audience for joining us. And please join us again at the same time on Sunday, when we'll be looking at cities for leadership in a post-COVID world.